So like I said, I'm Tim, I'm a fourth year, so I created these reviews because I felt like it would be helpful for me when we were getting closer to the shelf to have just like a quick review of everything, just to recap. So we'll start off with just some like questions and answers, kind of like Emma Holiday. And then in the middle, it's more of a, I made like a differential diagnosis section. And then at the end, there's like a rapid review with a bunch of like high yield, like rapid, like two word sentences and then like an answer, that sort of thing. So it can get kind of lengthy. So if I'm moving too slowly, I can just skip through some stuff too. Hopefully it works. Okay, so I'll read the question. So a 1-month-old male is brought to the clinic by his mother for vomiting for the past 6 days. He's not been able to keep any food down and his vomit appears formula colored and he's immediately hungry after vomiting. Which of the following is the best next step in management? Anybody feel free to shout out an answer. It doesn't have to be right. There's no pressure to be right at all.
Maybe abdominal ultrasound.
I was going to say ultrasound or x-ray.
Yep, exactly. And so I bolded some stuff here because I feel like the way I always thought about some of these questions is you see them and they're slightly different, but then there's the things that are always worth, like they repeat them because it's essentially what they're asking for. So 1-month-old, it takes about 1 month so it's pyloric stenosis is what this was supposed to be. And so it takes about a month for the pylorus basically to hypertrophy enough to actually cause an obstruction. So which obviously is important because there's other things that happen a lot faster that cause vomiting that we'll probably get to later. So the formula colored tells you that it was above the biliary duct. So there wouldn't be any bile, so it wouldn't be green. And then immediately hungry is just for some reason a buzzword they always like to use. Not sure why, but that always was something they threw in there as like, and for whatever reason, didn't use it for other things when I feel like you'd be hungry no matter how you vomited. So yeah, good. So the next question here, this is just like a follow-up. So this is the exact same question, so I won't read the whole thing over. But it's sort of like a follow-up because they can ask you sometimes what's the disease name, what's the management, what's the follow-up, those sorts of things. So sausage-like mass in the right upper quadrant, I already gave away what it was and you all knew it anyways. So what is the best next step in management now? Reassurance, 0.9% saline, 3% saline, or 0.45% saline or surgery?
It shouldn't.
0.9 saline.
Yep, exactly. And the reason being, which y'all already know this, but so isotonic fluids are almost always the right answer for rehydration scenarios. So reassurance, definitely not. I mean, something needs to be done, obviously. Surgery, that's the trick, I feel like, is surgery, because you do want to do surgery at some point, but you need to make sure they're volume resuscitated first. I don't think we have them in this PowerPoint, the reasons you do 3% or 0.45%, but 3% obviously would be situations where you have really low sodium, and then vice versa for 0.45%. So there's very specific scenarios on IM that you'll probably already have used. Oh, here's the slide. So isotonic fluids for resuscitation. So lactated ringers could be another one, but they like to use that more for surgery questions than IM stuff. And I kind of already said that already. Most of those won't. I would think those would be a little too out of the depth of PEDS related stuff to be on the PEDS shelf. Okay, so an APGAR question. So a 1-minute-old newborn female is evaluated shortly after birth. Her extremities are blue, pulse is 113. She grimaces, actively moves all 4 extremities, and cries loudly. Which of you wants to take a stab at this APGAR score?
I can try to. We'll do team effort here. So if the extremities are blue, that's only 1, rather than completely being blue and not being pink. So 1 point there. Pulse is above 100, so that's 2 points. So we're at 3. Grimacing, I want to say, is probably 1. So 4. Actively moving all would be 2. 6. Crying loud is good, so 8. I'd go with 8.
Yep, right on. And that is definitely there's so many different ways to do that, but yeah, the thing for me was remembering, I put one of the ones that I always forgot, which was grimacing, because that sounds like it's normal because G is for grimace, but that's somehow not the maximum score. So it seems like a weird scale, but yeah, so like you said, Stephen, that's a great way to do it, is calculating, adding up 1 or 2. You could also just start with 10 and subtract anytime if you just remember the things that are abnormal, like the ones, because 0 is pretty much absent, which you'll be able to tell pretty easily. If you remember the ones, then you can just subtract that from 10, and you could possibly figure it out that way if you didn't want to remember it. But you guys already probably remember it. I remember the case file stuff. I think he covers it for the midterm stuff. Okay. Newborn male with known diabetes presents with blue discoloration, a single S2 sound, a blowing holosystolic murmur, and then a funny buzzword of an egg on a string appearance of the chest x-ray of his heart. Which of these T words is most likely?
Maybe transposition of the great vessels.
Yep, that's what I was going for. I think I have a follow-up slide. So these are the highest yield of those. And you guys can definitely slow me down if I have questions. Sorry, I'm moving quickly because I know that if I don't, I usually don't get through the whole thing. But yeah, exactly. Good job. Transposition. So I put the first slide, or the first bullet for each of these is the underlying like mechanism, which they might use, but that's typically more like a step, like USMLE thing. But so if it doesn't spiral, the aorta and the pulmonary trunk don't spiral, they're basically vertical, and so they so the right heart goes to the aorta, goes to systemic circulation, which would be like you're sending the blood you just drained of oxygen right back to the blood. And then the left heart's just in this dead loop with the lungs, and so you need a connection in the middle, which there's pictures on the next slide. So you would need to have some sort of an external shunt to stay alive. Another hint is maternal diabetes. So if they say that the mom was like severely obese or had like this insanely high glucose, and then the egg on a string was supposed to be the helpful hint there, because otherwise these can often sound really, really similar. So truncus arteriosus sounds super similar if you think about what's happening. But it's slightly different. So the transposition is when it doesn't spiral properly, but truncus is when it doesn't septate. So instead of it actually spiraling around each other to get that loop that we normally have, instead of that, it's the lack of them being separate. So if you can imagine, if the trunk and the aorta were combined, you would send oxygenated blood back to the lungs and some deoxygenated blood to the body. So not great. And then the hint there is it's associated with DeGeorge syndrome, like most heart things. And then tetralogy is the PROV abnormalities, and also associated with DeGeorge. I won't read all of that because you've probably covered that in depth. So here's the picture. Tetralogy is the one we all cover in quite a big detail, but the D transposition, which is the one we most commonly hear about, is basically, you can see how they're both, I don't know if you can see my mouse, these are both very straight, and that's because they didn't spiral all the way, and then the aorta is attached to the right side of the heart. Normally it would be the aorta coming from an arch over here at this angle, and so it failed to spiral all the way, and so you got the aorta stuck on the right side of the heart. Does anybody know the answer to this bonus question? I thought this was a hard one that I remember seeing. Why does the VSD murmur decrease in intensity over the first few weeks that a newborn is born? That's a hard one. That's why I said bonus. I don't think they would ask you that necessarily, but I think it's interesting. So decreasing pulmonary vascular resistance. And so I put a little arrow diagram so if it was helpful. So when a fetus is in utero, it breathes purely liquid, which is higher resistance than air. So as you expulse the fluid whenever they're born, they start to breathe air, which is lowering the pressure. And so if you think about, if I pull my mouse here, this is the pulmonary trunk is where the pressure is high. And so if they're breathing a bunch of fluid, this is what's high. And so it shunts across here. And as this decreases and fills with more air, and I'm just saying this is in like the lungs, that direction decreases, then more flow can go through the pulmonary trunk, which is what's supposed to happen, and less flow goes across the VSD, which decreases the sound of the murmur. So it's interesting because you think later in life that it gets worse, and it does, but in the first few weeks, it actually gets a little bit better, just because the blood is moving in a different direction. Next one here, 18-year-old male presents to the ED after an episode of sudden onset weakness in his left arm at basketball practice. He has no significant medical history. and he has 2 out of 5 strength in his left arm, but normal in his right. Which of these heart defects do we think is the underlying problem here? Any guesses? There's definitely multiple right answers for this one. I will say that. I just think that there's a reason why I picked one, but there's multiple that are right. Okay, let's move to the next one. So PFO is what I was going for, but I know this one is hard because you could say probably the first 3 could probably be right, and here's why. I put it as PFO as the right answer. So it's because it's so common that if someone comes into the clinic and has this problem, or you see them clinically with this situation, it's probably a PFO. So it's like a quarter of the population has this, but is asymptomatic. So when I've seen it on a test, they'll put all 3 on here. And I always would think like, I mean, it could be any of these 3, but it's just a prevalence thing is what they're going for. So in a young person with no family history and an ischemic stroke on an NBME, definitely think this, not as maybe not the only thing, but definitely think of it at least first. And then you could also think of inherited coagulable disorders like factor V Leiden if there's a family history present. But if it's like a young person and doing an activity and has a stroke, that's just so uncommon. So what happens is do I have a picture on the next slide? I do. I'll wait to explain what's happening on the next slide. VSDs, though, are also super, super common. The physical exam finding is the holosystolic murmur at the left lower border. The next bullet point is kind of complicated. It was basically just trying to explain why the larger defects make less noise. It's just because there's less resistance. And so you think, like, if they give you the question where you barely hear the sound, but he's super lethargic, then that means the murmur is so large, it's not making that much of a sound. But nonetheless, regardless of the sound and the intensity, they always want you to get an echo if it's heard, even if it's tiny. Even though sometimes in real life in the hospital, they may or may not do this. On the test, they want you to do that. ASD, so the way you differentiate that is the wide fixed splitting of the S2. Basically, if the atria are here and there's a connection between the two, then some of the blood always shunts over and basically sends blood over the right side of the heart, which you know that the pulmonary side is the side that closes later. And so if you send more blood over, it causes a fixed split that stays wide because the blood is always shunting over. Whereas some of the other things like inspiration can change the split, but it won't be fixed. And then there's also could be a distractor murmur because you can imagine that if there's a septal defect, there could also be sound by the blood flowing itself. But the important thing is the wide fixed split. So PFO typically won't have a sound, but it will be that young person with a stroke. A VSD will have the classic buzz phrase there, and then same with ASD that has its own buzz phrase. So this is just sort of a picture to remember that the reason we hear the sounds where we do is because of the way the blood is pointed. So obviously APTM, and then it was also to kind of imagine, if you imagine here between the atria, there could either be an ASD or a PFO. And so blood comes up from the right side of the heart, goes into the vena cava, comes up into the atria, and then crosses over. And so if a clot came, like a DVT came to the heart, it could cross through, if there was a hole here, could cross through, send up from the left side and cause a stroke. So normal people who are young, unless they have a hypercoagulable disorder, shouldn't be able to have a stroke like that because a DVT would hit, it would go through the right heart, it would get stuck in the lungs, and you'd have a PE instead. So normal people with a totally closed heart circuit shouldn't be able to have those. Any questions? I know I'm flying through this stuff. Okay. So the next one, this one's ENT related. A 2-year-old boy presents with 3 days of right ear pain. His mom reports that he's had a fever over this time. He constantly pulls at his ear. He has a tense TM. It doesn't move in response to insufflation. I'm sure you've seen 1,000 of these in the clinic if y'all have been in clinic yet. Any guesses?
Let's go with A.
Yep. That was not meant to be a tricky one. I know there was plenty that have been so far. So the reason I put this was one, you all already know otitis media, but to talk about the other ones too. So fever is important. It's an infection, so that we'll have the temperature high. So the constantly pulls at his ear is important. I think I talk about it on the next slide. Yeah. The tense TM. So the diagnostic criteria is the no response to insufflation. So that's the main thing that you need to confirm the diagnosis. So I'll talk about some of these other ones on the next slide too. So here's the picture of the ear. So otitis externa would be basically from here until you get to the TM. All of this is the external ear canal. Otitis media is everything from here onwards. So if you just think of when you're trying to remember what the symptoms are, you can just think of what the region of the ear is. So you get the weird, almost looks like a labyrinth in the ear with otitis externa because you get inflammation of this part of the ear, whereas otitis media is the actual TM is inflamed. So an important diagnostic hint that they sometimes throw on tests is if you pull on the ear, it relieves the pressure. So if you think about where the TM is, if all of the inflammation is back here behind the TM, if you pull on your ear, you're essentially creating extra space. If you do it, you can sometimes pop your ears that way, and you're creating some extra space in your middle ear, basically. And so you're relieving some of the pressure that all the inflammation is putting on your TM. Whereas otitis externa, you can imagine the external ear is connected right here, right? So if I have otitis externa and I pull on my ear, that hurts. So the kids wouldn't do that because it would hurt, make it worse. So they would only pull on it to relieve the pressure of otitis media. They would leave it alone and say, don't touch it if it's otitis externa. But then if you examine it, you can tell either way. So the other hard question is, when do you treat with amoxicillin? And there's a variety of different ways to remember this, but definitely young kids that need to be treated, like, so less than 6 months. And then if you're older than 6 months, if you add in any one of these three things, if it looks really bad, then you can add in amoxicillin for treatment. And then you can also add the clavulanic acid if they've had a recurrence. So otitis media with the fusion is just basically the fluid. So it still might not be modal to insufflation, but look for that acute inflammation. There won't be acute inflammation. This could be a secondary thing after an acute episode, but it won't look as inflamed. It won't say red and irritated. It'll just say it looks like fluid pockets on the ear. And then we talked about otitis externa. Almost always there's some sort of history of inciting event. So even if they don't say they've been doing something to their ear, like swimming, because that's an obvious hint, like if they say they listen to music when they run, that would be pretty obvious too, or they fell recently or something. There could be any sort of trauma that could cause it as well. Those are pretty straightforward. It's usually the treatment that's kind of complicated. Otitis externa, you have to use fluoroquinolones because usually it's caused by Pseudomonas or something. So if they gave you an otitis externa, don't get confused and treat with amoxicillin. Usually that's not the right answer for treatment. That can also be confusing. Okay, we're moving on. So this is the differential diagnosis section. So y'all can just shout out things that come to mind when you think of these things. And then I have like a little flow chart on the next page to talk about how we can separate them. So what comes to mind when you think of bilious emesis?
Volvulus.
Mm-hmm. What else?
Intestinal atresia.
Yep. Got it. Any others? Both good choices. So here's what I put on the next slide. And this is not an exhaustive list. I just tried to focus on things that are tested on these shelves. So Hirschsprung's, meconium ileus, Stephen said volvulus, and then we talked about atresias too. So now, if you had gotten to this point, what would you do to differentiate between these conditions? You figured it's one of these, you got bilious emesis, and you need to do a test. Now what test do you do? This is different than the one we talked about earlier, because the other one, we know exactly what we were looking for. We just needed to zoom in on a specific location, is why we chose ultrasound. This time we go with something different.
And an x-ray maybe?
Yeah. I still don't know if I've seen, other than the surgery situation, where that's not the next best answer, because you can see usually with relative low radiation, you can see where the blockage is happening. So the question I always had was, well, when do you do surgery? And so I created this so you could have like if you had to pick a scenario where you do surgery and don't and it's the peds shelf, so there may not be surgery, but there'll probably be one question that's like XLAB or something. So when to proceed with surgery. So if they look severely unstable, so a blood pressure of less than 90 over 60, it'll be super obvious. Peritoneal signs, so rigid abdomen, rebound, guarding, basically any situation that shows the peritoneum is inflamed is definitely a reason to proceed with surgery. The free air here, which is this handy picture that you never have to do anything with because you can always just do surgery. And then inconsolable or unconscious, especially if they're really young and they can't tell you anything, but they're not responding to anything you're doing. Here's another example of free air. Free air laying down looks a little bit different than when they're sitting up. So yeah, the first thing is X-ray, and then next we would do surgery if you really needed to. And so I have the next slide here to talk about what do you do if you don't do surgery. So UWorld has a pretty good flow chart, I remember, but basically if you get, I tried to pair it up with the buzzwords here. So if you get the dilated loops of bowel, it tells you that basically at the point of the rectum, everything proximal to it is basically expanded because it's all blocked. And so now you have to determine if it's Hirschsprung's or it's meconium ileus. And so you would need a barium contrast, you need a contrast enema to differentiate the two. So, and then meconium ileus, I should have put a picture of the GI tract on here. So if you think about the ileocecal junction, meconium ileus, the vast majority of them happen at that junction. So the colon is small because there's nothing getting through to the colon. Hirschsprung's is the exact opposite. It's right at the rectum, so everything in the colon is big. So it's a giant colon with a transition zone versus a small colon, but you would do a barium enema or an air enema or whatever type of enema they give you that has contrast. X-ray normal. So if it's like, okay, they have bilious emesis, but we didn't see anything, then it's possible there's a volvulus that you just couldn't see. And so that's when you would do the upper GI series. And then you'll see the twisting or the corkscrew. And then the easy ones are the double bubble and triple bubble. If they say it, it's easy. And if they show it, it can be kind of hard because it's hard to count the bubbles. You have the two types of atresia. So I think there's a picture, multiple pictures. I'll just go ahead and we talked about them. So triple bubble, you have the one bubble here, you have the pylorus, the next bubble is the duodenum, and then where the atresia happens, there's the next bubble would be the jejunum after that. Double bubble is this one. The only bubble is the pylorus, and where the duodenum is blocked. Sorry, I said the wrong thing here. It would be the stomach, the pylorus, the duodenum, the jejunum, and then that would be where the atresia was. So there'd be 1, 2, 3. The corkscrew is pretty obvious, the volvulus, and then this picture shows the tiny colon versus the large colon. So the important thing, I think, like, yeah, maybe you'll have to understand the x-rays, but I think the important thing on these shelves is to pick the right pick the study to do, not to interpret the study. So if we review real quick, so if you see bilious emesis, you start off with an x-ray, assuming they don't need surgery. We talked about the reasons you would need surgery. And then from there, you need to use, okay, do I think it's an atresia? Then you can, you basically know based on the x-ray, if you think it's Hirschsprung's or meconium ileus, you need to do barium enema. So an enema, obviously contrast from the lower end because that's where the problem is versus an upper GI if you suspect volvulus or if it's normal. Okay, moving on. Next one is sore throat. I know you guys have a differential for this because I think this was in the case files thing.
Strep throat.
Good.
EBV.
Yep. What else?
Abscess.
Yep. That's a good one. Any others?
Epiglottitis.
Yep. All of these are good. I think some of those are on, I split this into 2 things. So those are all really good. All right, good job. So this is a very, very busy slide, but I'll just keep it to the simple things. So to me, whenever I was trying to determine if it was actually strep throat, I always tried to have this scoring in my head because usually if they're trying to get you to pick this, they will give you the greater than 2 score, and then you can go from there. So center criteria. And then so then the first step is to do a rapid strep test. It's highly sensitive and you can essentially rule it out if it's negative. And then you would treat with penicillin. But if it is negative, you don't just send them home and say, like, have a good day. You do a throat culture after that. It's just slower. So you want to do the strep test first because it's faster, and then you do the throat culture as a confirmation. And so then if positive, you also treat again. And so, but the tricky thing that's so confusing is that in kids, you do need to follow up with a throat culture, but in adults, you could just say, okay, if your if your rapid strep was negative, you probably don't have it. And then scarlet fever, I used this triad, and I still don't know if there's one where they tried to trick me, because it's usually pretty straightforward. So it looks like strep throat, they have tonsillitis, but then they have a strawberry tongue and then a weird sandpapery rash. But it's a little bit different enough from Kawasaki that you're like, it sounds kind of like Kawasaki, but it's not quite the same. So that would be scarlet fever. And so you treat it the exact same way. It's just a complication of strep throat. Kawasaki is 4 of the crash findings plus 5 days of fever, and then you basically know that it's the case. So to me, scarlet fever looks like a less severe version of this on tests. In real life, that's obviously not necessarily true. And then the important thing y'all already know is to treat Kawasaki's differently than pretty much everything else in this category. Aspirin and IVIG, and then EBV. The tricks are that they're older, so they're usually teenagers. The lymphadenopathy is posterior, usually, if they want to give you that hint. You can have the abdominal pain from the spleen is a site of lots of immune cells, so you can have splenomegaly, and then the weird rash if they give amoxicillin. So these are what I'm calling like uncomplicated sore throat, but some of these are obviously very severe. So here's the next slide with complicated sore throat. So y'all said some of these: retropharyngeal abscess, PTA, epiglottitis. So let's go through these. So these, to me, on tests are just like a matter of recognizing the word or the words they want you to pick as like, that's what we're going to say. So uvular deviation. So the uvula sits in the middle of the posterior oropharynx, and if one of the tonsils is inflamed, it's going to push the uvula to the other side. That one's pretty simple. But retropharyngeal abscesses, the abscess is further back in the posterior, like even laryngopharynx, and so it's going to be that it hurts to move their neck, or they won't move their neck, but their uvula won't be deviated because it's behind the uvula. It's not going to move it to the side. Then epiglottitis, the classic thing they always talk about is drooling for some reason. So croup or laryngotracheitis is the seal bark cough, and then the inspiratory stridor, because it's right where the larynx is, which is right where your airway is and right where you breathe in air. And so when they inhale, it makes a really loud noise, and then it causes the stridor, which I think we'll talk about here soon as well. And then assuming you do say you're like, oh, I thought that was a croup case and it didn't work, then you can assume it's bacterial tracheitis, which would be a similar thing caused by bacteria. And so you'd have to do a throat swab to check that, because it's bacteria, whereas croup is caused by a virus, parainfluenza virus. Okay, chronic stridor. Anything come to mind? And these are a little bit more vague, so any ideas for chronic stridor?
Like
There's
a
no
foreign
problem.
body.
Yeah, that's actually a good one. I didn't put that one in there, but that would be a good one to add. I know some of my descriptions are vague. I'm just trying to like jog your memory. Let's see. So this is what I was going for, is these 3 things. So laryngomalacia, vascular ring, and tracheomalacia. Laryngomalacia, the one is like, I feel like they literally always test. And so one thing that I felt like I never understood was why the stridor is the way it is. And so I spent time trying to figure out why the case is. So I drew this picture, I pulled up this picture here. So the larynx is obviously here, and then we're getting down into the trachea, into the lungs. So laryngomalacia, you can't really see it, but the trachea would be, or the larynx would be in this area. So the whole way air moves into your lungs is down a concentration gradient, or a pressure gradient, I should say. So you suck in air, decreases the gradient all the way down here, and air flows down this negative gradient. So when you decrease the air gradient to get the strongest airflow, basically you're inhaling here, so you need this to be really negative to get the air to start flowing in. So that's in an infant with a really collapsible larynx. When you inspire, they can, if their larynx is, if they have laryngomalacia, it will potentially collapse. But if you picture this random stick figure guy, if you picture him prone instead of supine, I had a better picture before, but if you think about the anatomy of the larynx, it looks like a triangle like this. And if you lay them forward, the larynx flops forward and stays open. Whereas if you lay them backwards, it tends to collapse more. If you just look at the way the epiglottis is set up, it makes more sense. So they improve with prone positioning. Vascular ring is where the aorta compresses right about here. And if you can imagine, there's not a phase that it's going to not be compressed. It's just there all the time. So it's going to be biphasic, but it does improve with neck extension. So if you imagine this guy extending his neck, the trachea now looks like a little bent like this. It's bending around the aorta. So that's why it improves this with neck extension. And then tracheomalacia is a little bit more rare, but they sometimes ask it in people who have been intubated for long periods of time. So again, when you expire again, you have to create a positive airflow gradient here to be able to push the air out. So if you create a large positive right here at the start of the trachea, with the collapsible trachea from being intubated for 2 weeks, the trachea itself can collapse. And so you get a stridor when you expire. So when you breathe out, you hear this exact same noise. And so you can differentiate. Usually, most of the things that cause inspiratory stridor are up here. Most of the things that cause expiratory stridor are down here for basically just for the pressure gradient. Does that make sense? Sort of. You don't have to say yes.
Yeah, that's great. Thanks.
Okay. Moving on. I guess I didn't put the transition on this one. So this is the 3 things that look exactly the same, right? So all of these have marfanoid habitus, joint hyperextensibility, skin laxity. So the important thing to remember, and you can just look at this later if you don't want me to read them all, but are the differences. So homocystinuria, the big one is thrombosis. So homocysteine, if it's super high in your bloodstream, is basically, I've always thought of it as like a sort of hypercoagulable disorder. So that's super unique to homocystinuria. The other 2 really won't have that, but also these other things are too. So if you remember Marfan, the Martian looks up to Mars is why the upward lenslet dislocation, and then downward is in homocystinuria. Marfan syndrome also has the valvular problems. And then MEN2B is the one that stands out because it's got the tumors basically. So the pheochromocytoma, medullary thyroid cancer, and then the mucosal neuromas. So that's the important thing. You'll see these 3 or 4 things and it won't really give you any help. The important things I've tried to bold, the super important things to help you distinguish them. And unfortunately, it's just a matter of just remembering them, but at least they're here. This is another tricky one I remember seeing on peds. So I didn't make it a question because it was super tricky. So coarctation of the aorta, which the picture is here, versus persistent pulmonary hypertension. So coarctation is just this narrowing right here of the aorta. So the subclavians on both sides go off before this blockage. And so you have the differential pressures in the extremities. So your arms have the pressure it's high because all the blood is stuck in your arms. And since it can't descend down in the aorta here, your lower extremities have low pressures. So the tricky one is persistent pulmonary hypertension. So if you imagine a baby that was born and had never adapted, remember we talked about earlier where pressures are originally high in the pulmonary circuit. And then as you become you're born and you start to breathe air, they should go down. That's normal. So in a PPHTN patient, for whatever reason, the pressure is still high, whether it's vascular or a congenital problem, or they were probably just cyanotic for an extended period of time. So there's vasoconstriction, the pressures are super high. And so what happens is if you can remember, the ductus arteriosus connects right here. It's not in this picture, but you can just imagine a connection here. So in these patients, the pressure ends up being so high that the blood ends up shunting through the ductus arteriosus into the aorta, and you send deoxygenated blood down to the legs. And so the thing I bolded here is that coarctation has higher pressures or lower pressures in the legs, whereas persistent hypertension has lower cyanosis in the legs. So that was I tried to bold the things that are the major things that I felt like were important to differentiating these 2. So if you got stuck with that, I feel like that would be a really hard question and kind of unfair, but I think that's how it would be a reasonable way to go about figuring it out. Okay. Differential for neonatal respiratory distress. Any ideas?
Coanal atresia.
Oh, that's a good
Diaphragmatic
one.
hernia.
That's also a good one. I really need to update this. I don't think I have either of those on the next one.
TTN,
Yep.
and then RDS.
Yep. All good. I pretty much got everything I had plus more. So I'll just go to the next one. So these are the three that I put, but you're right. The other two definitely apply as well. The reason I kept it to these three was because I think they're super important to be able to differentiate between the three. So NRDS, meconium aspiration, and TTN. So this next slide is super busy, but bear with me. So I bolded the things that I feel like are important for differentiating. So one, it's important to know the cause. So NRDS is because of a surfactant problem. When a baby is born early, they haven't had the surfactant to mature the lungs. TTN, if you're born too fast or you have a C-section and you can't exhale the fluid, supposedly when you're born through the vaginal canal, you're able to exhale all the fluid that they were breathing in utero. I don't know if that's true, but that's what I always told myself. And then meconium aspiration is when you've been in the uterus for way too long and you've passed your first meconium, and so then you inhale it because it's sitting in the amniotic fluid with you. So causes, that's how they're different. But then it's important, let's focus on the bolded things. So classic NRDS things are grunting and nasal flaring. TTN totally resolves, it's brief, and it won't look severe at all. It'll look like almost like it wasn't even worth mentioning, but they're just trying to get you to think it's relatively benign. And then the hint with meconium aspiration is the green color, because of obviously it's meconium. And then x-ray findings. So here are the buzzwords, but there's a slide on the next, pictures on the next slide. So ground glass and air bronchograms, streaking and fluid, and patchy consolidations. And so if you think back to the cause, all of these pictures, the x-ray findings make complete sense. Ground glass and air bronchograms, if your alveoli are collapsed, the only thing you can see are the bronchi, which are the air bronchograms, are basically the bronchi still being open, but the alveoli are collapsed. So the ground glass appearance is all the collapsed alveoli, whereas the bronchograms are the bronchi still intact. The streaking and fluid is essentially fluid in the lungs. If you weren't able to exhale the fluid as you were passed through the vaginal canal, you would have fluid in your lungs. And then the patchy consolidation is all the random pockets of meconium that they inhaled going to their respective alveoli. And then here's other hints. So preterm, post-term, and then look for a C-section or a rapid delivery for TTN. Do you want me to read all of these? I think they're important, but you can read them on your own too if you want, if I'm taking too long to read. So the treatment is also important to know the differences. Meconium aspiration is definitely worth knowing because you need to intubate before you suction, just in case you lose the airway. Whereas NRDS, you could potentially treat with just some positive pressure ventilation. You may need to follow ACLS, and then TTN is just supportive. It's going to totally resolve. So here are the pictures. So you can see some here and some there. Air bronchograms are basically the dilated bronchi trying to send air to the alveoli that are collapsed. This, I think, is a really telling picture of TTN. If they haven't exhaled the fluid, there's just fluid sitting between the fissures of the lungs. So that's what all these lines are. This is a little pleural effusion from the fluid. And the meconium aspiration looks like this diffuse, almost looks like malignancy, just because there's patches of basically white spots everywhere. So it's worth it to know the differences. But if you've ever wondered, like I did, what the heck air bronchograms were, that's what they are. It's just the dilations of the bronchi that can't send air to the alveoli. Okay, almost done with these. So hip pain. What pediatric related hip pain things do we know?
Slipped skippy.
Yep.
Leg calf Perthes syndrome.
Yeah, so basically all the names that no one can pronounce. Yep. Those were good. Any others?
Septic
don't know if you-
arthritis. Were you going to say that, EK?
No, I was going to say avascular necrosis, but I didn't know if we also put that.
Yeah, yep, those are all right. I think you basically covered them all. So the only other one I think, I guess, was the transient synovitis, but yep, Skiffy. The LCPD is avascular necrosis, exactly, and then septic arthritis. So this one is also super, super high yield. So the key things to know are the demographic is a huge hint for this one. And then the physical exam can sometimes be helpful. And then the treatment is also super helpful. So transients, or it can be called toxic synovitis, especially on older tests like shelves, is basically just an inflammatory response to a recent viral infection, but it almost is like TTN of the hip. It's gonna totally resolve, and so you don't do anything serious for it. Rests and NSAIDs. Whereas SCFE, it's an obese or tall adolescent, basically anything that's going to cause a ton of extra wear and tear on the hip as it's trying to form in the joint. And so the hint is that they'll say knee pain, but it's not their knee that's actually the problem. Their knee is just getting referred pain from the hip. If you think about a person walking, that if your hip doesn't work, if you've ever had like an ankle injury, you can sometimes hurt your knee after you have an ankle injury because all your weight transmits to your knee. Anyway, so you need surgery to treat that. And then LCPD is a younger child, so versus SCFE is an older child. And then it'll say the limited internal rotation and abduction, which I'll talk about that in a second. Actually, I'll just kind of demonstrate. So if you imagine the hip joint is right here, if you actually, I'll do the slide. That's not going to make any sense. And then septic arthritis, they just look severely infected. There's like a score. If they have a fever, a white count, they can't bear weight, and then ESR, I think those 4 as diagnostic criteria for septic arthritis. So you need to drain the joint and do IV antibiotics. So I'll go to the next slide and see if I can describe what I was trying to say with Perthes disease. So you can imagine if the hip problem is really in the acetabulum here, if there's avascular necrosis, if you adduct and internally rotate your hip, you can almost feel that you're shoving the hip further into the joint. And so if the joint problem is right here and you say, hey, I'm going to shove this part of your hip into the acetabulum, it's going to hurt. And so that's why they like you to know that the abduction and internal rotation is what causes pain. And then this is SCFE. So this is the acetabulum and this is totally slipped from the head. So it's worth seeing the pictures. So the demographic is huge. The Perthes disease is a younger kid. They're usually not obese or tall. SCFE is like a 10 to 16-year-old older sort of kid. And usually like it'll say some outrageous BMI, or they'll say they're like 6 foot and they're like 12. So something like some big discrepancy in terms of height or weight there. Do those make sense, how to separate those? I don't know if I kind of rushed through that. It can be super subtle sometimes. If they don't give you an x-ray, it can be really, really subtle.
No, that's awesome.
Okay. I think we have a couple more, maybe one more of these, and then we're almost done, almost to the rapid review part. So bloody stool.
Neck.
You got it. That's definitely on there. What else?
Meckel's diverticulum.
Yep, Meckel's is a good one.
A fissure.
Yep,
Milk allergy, like proctocolitis.
yep. Those are all, y'all are like nailing these now. Okay, so I kept it, again, there's probably some on here that y'all didn't, or there's some that should be on here that y'all mentioned that aren't. And the reason I did this is because it was a very specific demographic of things that I wanted to distinguish. So the milk allergy and Meckel's are typically painless, whereas constipation and intussusception are typically painful. And I think you could imagine why these two are just basically, Meckel's is just essentially, I mean, it makes a ton of sense why it's not painful, I guess. The milk allergy is basically just the immune system reacting to the food that they're eating. And so it can be bloody, but it's not necessarily painful because there's not some large object obstructing your colon like there would be with constipation or intussusception. If the colon telescopes over itself, you can imagine that they're really painful. So the first thing with like a toddler age patient with bloody stool is definitely to do painless versus painful. And then from there, there's the hints. So the painless things. So milk allergy, so they'll say they had eczema when they were a kid, or the stools are loose, or so on and so forth. I keep forgetting to finish the sentence here. So this is supposed to say, if they're breastfeeding, then you basically switch to a soy-free and milk-free formula because they could be allergic to either of those two. That's typically what you do. And if they're doing formula, you switch to the soy milk-free version of that. Or sorry, for breastfeeding too, the mom also needs to stop drinking milk or soy products, I think, because it obviously can contribute to the problem. Meckles is the rule of twos. So a 2-year-old male, 2 inches long, so on and so forth. And really, so if you're like asking me right now how to differentiate these two, I would say that this will be like, if they gave me no hints, I would probably pick Meckles. But then if they said eczema, all of their family members are allergic, they're like just changed formulas, like in the OSCE or whatever, then I would say the milk allergy. Constipation will look like constipation. They'll have hard stools, like you said, the anal fissure. And if they have the anal fissure, it'll be really, really painful. So it'll be easy to distinguish. And then the big one, intussusception, almost nothing else is super intermittently painful like this. So the bowel telescopes on itself, really hurts. Then they do something to reduce the bowel again, and then it's totally gone. So they'll be back to playing normally, basically, in between these episodes. And you might see, which kind of sounds like pyloric stenosis, the sausage-shaped mass, depending on where the bowel telescopes, it could be in the right lower quadrant or right upper quadrant. And then currant jelly stools would be really nice if they would give us that, but they don't seem to like to do that anymore. So currant jelly stools is also a big buzzword. So I would start with painless and then painful, and then I would use random hints to get me from those two to the next, basically to the answer. Okay, delayed passage of meconium. I think we touched on this already a little bit.
CF.
Yep. There's one more big
Hirschsprungs.
one. Yep, got it. So I added this third one on here because I was offended whenever they asked me this one time. But the two you typically think of, I think 95% of these cases are caused by meconium ileus or Hirschsprungs. So we talked about it a little bit earlier. Meconium ileus, the blockage, if you think about the location, it's at the ileum, so the colon is small. Hirschsprungs, the blockage is at the rectosigmoid, so everything is large, proximal. But then also meconium ileus will have some sort of cystic fibrosis hint, because the vast majority of these are caused by cystic fibrosis. So it'll be the thick, green, like sticky meconium versus either explosive diarrhea or like normal meconium, or whatever the case may be for Hirschsprungs. So the reason I put hypothyroidism, I highly doubt they would ask you that on the shelf. But if you saw a delayed passage of meconium and it just seemed really odd, it didn't seem like it fit either of these two, and you're like, okay, they don't have their hypotonia, they're jaundice. It really does sound like hypothyroidism, and it's been 3 days and they haven't passed meconium. I think that's a valid reason to pick hypothyroidism. But for the most part, like 9 out of 10 questions, it'll be basically picking between those two. So just remember, meconium ileus is caused by cystic fibrosis. And so you can think of secondary findings of CF, and then Hirschsprungs. If you imagine someone right above the rectum, complete loss of the ganglia, and you can't move the bowel, then it will be stuck and everything will be blocked up proximal to that. Okay, now we're to the rapid review. So genetic syndromes. So these are just like a couple of buzzwords that I think are super important, and then you can just shout out an answer. And I really do think probably 80% of these I've seen on a shelf or a shelf-related exam at some point. So slanted epicanthal folds, a single palmar crease, a sandal toe, and then brush-filled spots on the iris. I try to throw in as many hints as possible.
So
So
21.
Yep. Got it. Happy demeanor, seizures, gap between the teeth, intellectual disability. So I'd say this first slide, I think I saw every single one of these on my shelf exam, and I somehow still remember it because I put them here, and now I'm not like forgetting that I remember that I saw all of these on there. So FYI, there's a lot of genetic stuff in terms of just like recognizing the disorder on the shelf.
Is this one Fragile X or is it?
Angelman.
Close.
That's what I was gonna say.
Yes.
Angelman.
Yeah, those are hard. So I think there is a Fragile X. So once we get to that one, we can talk about the differences. So yes, this was supposed to be Angelman. So I won't say that actually. I'll wait. So it's a maternal deletion of the 15q11 through 13. So the way that at least I remember it is the Angelman is the M for the maternal deletion. So if that helps, or you might have your own way of doing that. And so now we have a history of hypotonia, obesity, short stature, behavioral problems, aggressiveness.
Prader-Willi.
Yep. So this is Prader-Willi. So this is the opposite version. So the P in Prader or Padre for paternal deletion. So the hard part is remembering that the alliteration, the M, is talking specifically about the deleted chromosome. So that can be tricky to remember. But yes, exactly. Prader-Willi. Next one. Friendliness with strangers, elfin face, a really weird heart condition, supravalvular aortic stenosis. This one can be a little bit harder. So that's supposed to be Williams syndrome. One of y'all might have been about to say it, sorry. The supravalvular stenosis is not like a thing that they ask all the time, but if you see that in a kid like this, then you can basically take it to the bank. You know the answer to the question. So it's just a really weird heart condition that happens in children with Williams. So it's a 7q deletion. So next one, high-pitched cry, microcephaly. And the reason I didn't give you any other hints on this one is because anything else they give you would probably be a distractor on this one. So this one was supposed to be the cry of the cat. So this is a 5p deletion. Knowing the deletions isn't super important for the shelf, but I threw it on there just in case you didn't remember it, because it can be helpful. So the only two things I remembered with these two are the high-pitched cry and the microcephaly. There's like, what was the other thing that I think sometimes they would give Down syndrome patients as having a high-pitched cry, and there might have been one other thing. But if it's just a high-pitched cry and like almost nothing else, then I would pick this. So midline defects, polydactyly, holoprosencephaly.
It's like Patau or Poto or whatever, however you want to say it.
Yeah. Patau. So this is trisomy 13. So this is worth knowing the number on this one because they may just say trisomy 13. So I put midline defects because all of the cleft lip, the aplasia stuff is all sort of centered in their midline. That's kind of the vast majority of their problems are related to like a midline problem. So the holoprosencephaly is basically where the neural tube doesn't form properly on the head. So that's also a central like midline problem. So if you want to just remember midline problems for Patau plus the P for polydactyly, the extra finger, that can be helpful. And then here's the counterpart, the prominent occiput. Instead of multiple fingers, they're overlapping, and then you can have jaw problems. So either a retrognathia or micrognathia.
Edwards.
Yep. So this is Edwards. So this is trisomy 13. So it's important. If you want to, you could simplify it and say, well, I'm just going to pick based on the fingers. The problem is if they don't give you the fingers, it can be hard. But if you want to remember, Patau is the polydactyly, so it has the extra fingers, whereas Edwards is just the fingers are just clenched like this and overlapping. I don't know if that helps. Okay, some more syndromes. Narrow epicanthal folds, smooth philtrum, thin upper vermilion border.
Fetal alcohol.
Yep. And this can be tricky too, because they can sometimes put the narrow epicanthal folds can confuse you with Down syndrome with trisomy 21. The trick though that I always used is, for whatever reason, the second two, thin upper vermilion border and the smooth philtrum, seem like the dead giveaway that they're trying to give you this over Down syndrome. So if it's something to do with epicanthal and you can't remember if it's the right one, but you get a smooth philtrum, I think you're probably safe to pick fetal alcohol syndrome. Sometimes with these, that's all it comes down to is just one buzzword that they want you to pick, and they'll throw in some overlapping findings that makes it really challenging, and so you can be hard pressed to figure it out. But then if you just keep the one or two things that you know that you're always going to go with, you can get it right. Omphalocele, large tongue, half of their body is enlarged, and they have Wilms tumor. These are getting more into the weeds, but I think they've still shown up before.
Is this Beckwith-Weidman?
Nice job. Yep. So I hope I put the ones that are, no, I didn't. So yeah, so the important thing with this one is that this can cause Wilms tumor, which is obviously nephroblastoma, but it can also cause hepatoblastoma, so cancer of the liver. So the way they might ask this is they might give you this syndrome, tell you the disorder, and then say what screening do they need. They would need an ultrasound for the Wilms tumor, and they would also need an AFP for the hepatoblastoma. So they may ask it a little bit more complicated by throwing what screening you would need. I'm pretty sure I actually saw that on my step 2 exam, which is kind of interesting. Fun fact. Okay, choanal atresia, heart defects, and ear anomalies. There might be an acronym or two. Yeah,
Charge.
got it. Those are the 3 big ones. I feel like renal and genitourinary are like half the other disorders. So I put the ones that were like, there's not a whole lot of disorders that have a bunch of ear anomalies. So I thought that was interesting. And then the choanal atresia too. TEF, anal abnormalities, scoliosis. Also another acronym. Sorry.
Bacterial.
Yep. You guys got these. Hypotonia, jaundice, umbilical hernia, large tongue. So this kind of sounds like Beckwith-Wiedemann, like what we were just talking about, but it's a little bit different.
Congenital hypothyroid.
Mm-hmm. Yep. So I always thought it was really tricky sometimes because these could have a ton of overlap. Because they can both have a large tongue, they can both have the sort of abdominal looking thing. I'll say that Beckwith-Wiedemann, they pick omphalocele more often than not, whereas congenital hypothyroidism, they usually pick umbilical hernia. And then it's so tricky. The hypotonia, I would probably pick hypothyroidism, and then they would throw in like a large limb or something. That would be a super big hint. But those can be really tricky to differentiate for sure. I should have bolded hypotonia and then the right arm and leg enlargement, because I feel like that those would be the big things I would use to pick the difference. Self-aggression, crystals found in the diaper, poor tone, another hypotonia here. Might be a catchphrase for this one. Might be kind of outdated though. I'll go ahead and do it. So this is Lesch-Nyhan. So this is the basically inherited form of gout plus other things. So they can't break down uric acid. So the crystals, they can be found in their diaper. They can have poor tone and self-aggression as well. So like they'll just like either pick at their skin or bite themselves or whatever the case may be. Long head, large ears, and intellectual disability.
Is this Lindsay's Fragile X?
It is, yeah. So what was the one we were talking about earlier? I kind of want to scroll back to that one. This is
Angelman?
fragile. What was that, Stephen?
Wasn't it Angelman where?
Yes. Yeah. So the big thing, so yeah, you're right. They both can have the intellectual disability. So the Fragile X, everything just sort of elongates and becomes enlarged. So the long head, large ears, like everything is just sort of stretched. And then Angelman, it's more so the like the hand flapping, they're like super excitable, like they can have a high-pitched cry. And then there's an interesting, the gap between the teeth is also super unique. But yeah, they can look super similar. I imagine in real life, it would be pretty hard to tell, but this one's also, I think, is pretty tricky. Nephrotic syndrome, genitourinary, and another Wilms tumor. Another syndrome that has Wilms tumor. Any guesses?
Is
Yeah.
this the one that also goes with the not having an iris? Okay, never mind.
No. That's actually a really good guess. I had to think about that for a second. So this is Dennis Drash. What you're talking about, I believe, is Wager syndrome, which also is related to Wilms tumor. So that was good. I didn't put that one on here, but yes. So this one, so there's 3 main syndromes basically that can have Wilms tumor. Beckwith-Wiedemann, which we talked about, Dennis Drass, which is this one, and then Wager syndrome is the one I think you were thinking of. So I think that's Wilms tumor aniridia, the lack of the iris, genitourinary, and renal, I think. So also a really good guess. That one's not on here though. Okay, so we'll move on to congenital infections, and then we'll call it good. The last few, I think these are the highest yield out of these.
Okay, this is either congenital CMV or toxoplasmosis.
Yep,
Which one?
Go CMV.
that's the trick. Yep, CMV, and the reason, actually, let's wait a second, and then we'll see if we can figure out why. So hydrocephalus, chorioretinitis, and diffuse intracranial calcifications.
This one is toxoplasmosis.
Yes. Yep. So the big thing, and I remember having the trickiest question on this. So if nothing else, try and pick based on the type of calcifications. So CMVs are right next to the ventricles is one, and then, but they also can trick you and they won't say it, they'll just show you. And so try and, if you see the calcifications are only along the ventricles, definitely go with CMV. If they're just kind of everywhere, go with toxo. And then there's also, the problem is a lot of these sort of these other things can overlap. And so if you rely on whatever it is, microcephaly, that can sometimes be in both. And so really the easiest way to do it is the calcifications. Everything else can be kind of confusing. But yeah, those are tricky. Skin scars, cataracts, limb hypoplasia.
Varicella.
Yep. That's good. So yeah, varicella, it's one of the only ones that has these really weird skin findings, and you can imagine it's this sort of a similar mechanism that causes chickenpox. So yep, skin scars, that's a super unique one, worth knowing. Jaundice, cataracts, deafness, and a continuous murmur.
Rubella.
Yep. Hopefully that one's on there and you can all get some free points. The snuffles, skin rash, so another skin one, but then some teeth and bone abnormalities that may or may not have a name to them.
Syphilis.
You got it. Syphilis. So the tricky part is that initially when they present, they may only have rhinorrhea or maybe a skin rash. The teeth and bone things are later on. So if they say they present one day after birth, they may not have teeth and bone stuff. So don't write that off that it's not syphilis without the bone and teeth stuff. It could definitely still be syphilis. Okay, and then what things do we think of that happen that cause hydrops fatalis?
Fifth disease or slap cheek.
Yep. So I put a couple things on here that I've seen. So parvovirus is definitely the big one. So the slap cheeks or Fitz disease or exanthum subitum. I think there's so many names for this thing. And then alpha thal and CMV can also cause hydrops. So the nice thing is if you do see the word hydrops fatalis in a question, it narrows it down quite a bit to a couple of things. And then you got to figure out based on the other stuff, which one of these things it is. So that's the hard part. But at least you got it down to 3 things maybe, or maybe y'all have a couple others, but I have it down to 3 things. Okay, here's a funny one, neonatal sepsis and widespread abscesses. This one's tricky because we're always taught the different causes of neonatal sepsis, and this is the one that has the weird secondary finding they like to ask. Yeah, this one's hard. So this one's supposed to be listeria. So listeria is like, I think it's in terms of bacterial neonatal sepsis, it's like the 3rd most common. But if you see widespread abscesses, so like they're either found on a scan or you see them everywhere, then that is a huge buzzword. That is definitely worth picking. And then encephalitis, sepsis, and vesicular skin lesions. I don't know if
Got the
I've talked about
herpes.
Got the herpes. Yep. So that's on OB. Y'all will probably some of you have already had it. Y'all will talk about the prophylaxis for pregnant women who have active herpes specifically to prevent this from happening to the neonate, because herpes simplex in a newborn is a lot worse than it is for people who have gotten it once they're older. So, and I think we have murmurs. Do you guys want to do murmurs or do you want to call it good? It's been over an hour, so I don't want to keep you if you don't want to stay. I'm not offended either way. Okay, let's do like 2 of these and then we'll be done. This one, because I said it earlier, harsh holosystolic murmur at the lower left sternal border.
VSD.
VSD. Wide fixed split and some other random murmur that nobody cares about because the only thing we care about is a wide fixed split.
ASD.
ASD, yep. Let's do one more that we haven't talked about yet. A continuous murmur that you hear when you listen between the scapula.
PDA.
So yes, I would say yes, but it's tricky sometimes too because so the reason I said interscapular is if you think about the aorta, it arches and then when it descends, it is basically at your back. And so the reason the coarctation is usually interscapular is because it's really, really close to the back. But you're right, that could easily be a PDA. Here's if you wanted, this is what I would maybe say would be like more PDA, but both of them could be true. The point of this was to kind of just talk about both of the continuous types of murmurs. So machine-like would be a hint, infraclavicular because the ductus arteriosus is connecting kind of right up in this area. So the location may be a little bit different, but I would think it'd be pretty rare for them to differentiate between those two. They just throw one of them on there usually. And then to avoid, do you think you guys are going to click through these later, the rest of them? Or I can just click through them real quick, probably not. Okay. So this is an interesting one. This is another continuous murmur, but it's related to the jugular veins. So this is supposed to be a central venous hum. So that's rarely shows up, but if it does, if you know that, that'll be money because that's a tricky one. Basically, there's just excess flow coming through the jugular veins that's causing a continuous murmur. And then when you turn the neck and you compress the veins, or if you just push on the veins, it decreases the blood flow and the murmur goes away. So this one's the trisomy 21, the Down syndrome murmur. So this is the common AV canal. So it's sort of a VSD plus an ASD plus just a giant hole in the middle. So it's going to have a lot of different murmurs. But if you see a trisomy 21 patient with a murmur, this is definitely the go-to. Systolic lower left sternal border increased with Valsalva. So this is worth going over. So they might have passed out when they were exercising, playing basketball or something.
Open.
Yep. So the reason I put that is, I didn't put the other one in here. I think I might have deleted it. Is because it can sometimes be confusing, HOCM versus aortic stenosis, because of it's systolic, it's in the same location, but Valsalva does something different. So Valsalva, when you Valsalva, you decrease the venous return to the heart. And so in HOCM, you basically have this obstruction in the left ventricle. And if you don't send enough blood to the left ventricle to open that, it's going to be worse. It's going to be super close together. So Valsalva will make it worse. You're decreasing the preload. Aortic stenosis, though, is different. It's a narrowed valve. So the murmur gets worse when there's more blood going across it. So it actually would decrease in intensity with Valsalva. If you Valsalva, you decrease the blood that comes to the heart, less across the valve, and so it decreases. So it'd be the exact opposite with aortic stenosis, which won't be super important for peds. So these are also pretty useful, but you probably covered these in depth. So CGD has staph positive, like what's it called? What's the word? Catalase positive organisms. So the tricky ones are Pseudomonas and Serratia. Everybody knows staph, so they'd like to throw some weird things that are catalase positive. Pale skin and peripheral neuropathy. And then the inclusion bodies is Chediak Higashi. So that's a weird one. Delayed umbilical cord, skin infections with no pus. That would be leukocyte adhesion deficiency. So that's where if neutrophils are stuck in your bloodstream and they can't get out into the skin infection, you won't have any pus in your infections, and you'll also have the blood will be full of neutrophils. So the white count will be extremely high, like in the hundreds of thousands even. So infections, itchy rash and thrombocytopenia is the Thai mnemonic for Wiskott-Aldrich. that one's kind of tricky. That's supposed to be XLA. You basically you completely lack IgG and every immunoglobulin basically. So immunoglobulins help you deal with parasites. They help you deal with encapsulated things. So H. influenzae and strep pneumonia are both encapsulated, and Giardia is a parasite. Both of those are basically your body's main way of getting rid of them is antibodies. And if you don't have antibodies, you can't get rid of them. Okay, and these last few are relatively, you see them quite a bit. So that is it. So I'll stop recording. Bye.